All right. Okay. We're good.
Yeah.
Thank you, Dr. Tamarish, and very good morning, all of you. This is Dr. Sarana Kumar, the Secretary for Society for Emergency Medicine India, and I'm today representing SEMI in this ASEM meeting. Thanks for the meeting organizing, Dr. Tamarish. Let me give you a brief summary on the terms of what Dr. Tamarish has already spoken. India so far seems to have done quite well in terms of its preventive aspects, where the social distancing and lockdown has really helped so far only to contain it at stage 2. We haven't seen stage 3 community transmission yet, even though we are hearing few reports of cluster cases. As of today, we have 6,000 plus cases across the country, with about 150 of them didn't survive. So this is the current statistics across India for a population of 1.3 billion. I think this is not bad at all, considering the fact we had our first case almost at the similar time of what Europe and US experienced. So that's one. So coming to the preparations in terms of PPE, I think luckily for us, we had a bit of time to prepare and also learn from the world on best practices across. So we were managed to keep our supply chains open, and manufacturing PPEs were also kept on pipeline. So the current stock across the institutions and hospitals seems to be all right, at least for months of usage. But what's concerning here is some of the survey done in Indian emergency departments say we are burning our PPEs much faster. For example, about 500 PPEs per single positive case. So the risk involved here is we might run out of PPEs shorter. So one of the key points here, as Dr. Tamarish mentioned earlier, is how we are going to recycle PPEs and what is the criteria we're going to come out with, so that like we have some kind of a reuse policy or a statement from ASEM on the PPEs, especially the N95 masks. So that's two. Few of the other advocacies which India has done quite well is also on bringing the frontline workers and taking care of the frontline workers. So clearly there is clear quarantine policy. The two things which I wanted to mention here. Indian government clearly said anybody more than 55 years should not be working in frontline. And number two, probably India is the first country which has introduced a special insurance package for anybody who's working in frontline, be it emergency department staff or doctors. Are closer to $70,000 US per doctor in case if he has to, in case unfortunately if he loses life in this battle, or 2 lakh rupees in case somebody falls sick. So these are some of the government level advocacies we were able to bring about, and I think other countries should also probably consider this. So these are some of the positive aspects. Some of the concerning aspects is currently the question mark on are we testing enough in India? Because only the RT-PCR is available now. We still haven't got the kits to test the IgM or IgG, which is expected to go on to flows in another week or so. So with this status, I think we might start seeing more numbers at the end of April or early parts of May is the predictions now. So currently, we are in the preparatory phase and holding strong. Thank you, Dr. Tamarish. Back to you.
So with this, I just want to add one more point. Thanks, Savana, for that introduction and quick summary, is the use of hydroxychloroquine. And this has come, as media hype one country's request to serve hydroxychloroquine. We are seeing large number of patients coming to emergency rooms asking for this drug. And in some of the cases, there are side effects of hydroxychloroquine which has been seen. And the patients with cardiac arrhythmia are also presenting to emergency rooms. There are two other things which has happened just in last couple of days. Is there are cardiac patients who are admitted inside the hospitals and they are found later to be positive. And then that resulted in quarantine of healthcare workers, including people who worked in emergency department and encountered those patients. Day before yesterday, there were patients who came for chronic dialysis And of course, most of the patients are now routed through emergency department. So dialysis patients later came positive are also visiting emergency departments. So these are the two things I wanted to add to what Savannah said. So I'll not now like to, we will take questions at the end, or if you have any immediate questions, we can take it right now for Savannah as well. Okay, so I'll now request Axel to give us an update.
Yeah, okay. I have a file to have my presentation. Okay. Okay, can you see the PowerPoint file?
Yes.
Okay. So this is the current situation report from Hong Kong. So this is the current statistics. Well, in Hong Kong, we started to have the first confirmed case on the 23rd of January. This is about 3 months ago. And since then, we have the gradually, basically, most of the time, we have the cases, confirmed cases every day. And up to now, we have 990. Probably there will be exist 1,000 today. And only 15 of those patients were considered to be criticals. And the number of deaths up to now was only 4, and we have the 309 patients has been successfully discharged from hospitals. And the current changes that we encounter in Hong Kong, first of all, just like the other parts of the world, is the inadequate PPE, especially for N95 masks, and also because of the great numbers of the patients that we need quite a number of those airborne infection isolation room. That's the demand is very high, and we resulting in quite significant tension for those requirements, and also because of the stress in both of the physical and the mental stress, not only for the emergency physician, but also for those healthcare workers working in the in clinical area, especially for the isolation ward. And because there's a lot of people that actually related that have been classified as a close relationship with those confirmed cases. We, according to the current policy, they will send to the quarantine camp. So we have the problem of getting adequate space for those quarantine camp, because we have some people, they have some concern about whether with the camp was set just very close to their home. They raise a lot of questions and also disagreement with the government. So it's very hard for the government to identify places to establish this kind of camp. And after the first few weeks, actually this started from last month, and because of the infections spread to the other part of the world, especially for Europe and also to USA, and quite a number of the especially in Hong Kong, we have quite a number of overseas students. They actually they go back to Hong Kong, and because they fear of those situations in where they study. So and we found that there are quite a number of those citizens or the returnees from overseas. They turn out to be positive for COVID-19, and which actually it's make us the number of those to be not. At one day there will be 65. This is a maximum quite significant for an impact to our healthcare systems. And also because Hong Kong is very crowded, to initiate those although we have the advocacy of social distancing. However, this is not easy to implement in those very small parts of the world. And I can show you this. This is the we have some temporary measure, because we try to separate those suspected patients who are waiting for the investigation result, and or even for consultation. We try to allocate some area, usually will be outdoor and just outside the emergency department, to use a canopy or tent, so that we ask those patients to wait. Most of the time, because they are quite quite stable. They maybe only have some URI symptoms or low-grade fever. They will stay here unless there's those critical conditions. They will be immediately sent to those airborne isolation room for treatment. Otherwise, they need to stay outside one by one. Depends on the availability of those isolation room for consultations. And this is another example from the other hospitals. And the current strategies in Hong Kong to control the disease, first of all, is containment. All the people with who found to be close contact with those confirmed cases will be sent to quarantine camp for 14 days. And now we have all those Hong Kong citizens, they return from overseas will be subject to a compulsory quarantine. Other they will be they can select to stay at home or in a quarantine camp for 14 days. And for those travelers from mainland Macau or Taiwan, no matter whether they are Hong Kong or non-Hong Kong residents, they will also subject to compulsory quarantine for 14 days. And we try to stop those because we find that quite a number of those confirmed cases are related to the positive travel history. So we stopped all those non-Hong Kong residents from overseas to Hong Kong, and then all those they will be denied for entry to Hong Kong. And even for those from mainland Taiwan, they will be subject to if they have been visited to overseas in the past 14 days, they will not be allowed to go to Hong Kong. And also we stopped all those transit flights in the Hong Kong International Airport. And also we try to initiate policy for early detection. So for those returnees, there is a mandatory process for deep throat salivary test for the COVID-19. And also, if those returns from returnees from in the airport, we have symptoms, they will send to a designated center just next to the Hong Kong International Airport for the MPS and also full swab. And even for now, the policy has changed. For those who come back from UK, there will be a compulsory test in the designated center until the result is available before they can go back for home or designated area for the quarantine. And the other strategy will include social distancing. We try to forbid all those gathering for more than 4 people in public area. For those non-emergent services in non-essential services in government, they will arrange for home office, and also we close all the amusement center, bathhouse, fitness centers, karaoke, nightclubs, everything. So that try to make sure that people will stay at home instead of going out for gathering. Because in the past we have quite several occasions of those clustering because of those gathering that spread the disease. And even for restaurant, they need to have some spacing, and also not to have more than 4 persons per tables. And also we close school since the Chinese New Year's already. And we also implement a very strict personal and environment hygiene. Basically, everybody on the street will wear a surgical mask, and government also remind everybody to keep on the hand hygiene. And for the hospital-wise, because we have the problem of the availability of the AIIR, we try to develop a second theater isolation ward. So that in that case, for those we cater for those who has been very mild, improving, and no sign of any hemodynamic instability, they will be moved to those step down ward in such a way that there will be a ward instead of 1 person per ward. Per room, there will be, for example, there will be a 4 to 6 bed in a ward, so that they can release the tension of those Theater 1 isolation ward. And we have also very well delineated criteria for admission for those who need to be admission. In the A&E department, we initiate those 4 theater system to determine the management of those patients. For Theater 1, basically this is those patients with fever or with URI symptoms or even pneumonia. They have positive travel history within 14 days overseas, or they have close contact history with a confirmed case. They all will be admitted unless they are for those or unless they have very mild symptoms, because we do not have adequate AIIR. So for those we select some of those cases, or mild cases, that is not a pneumonia cases, do have an MPS and in the A&E department, and they wait for the results before the final decisions. For Theater 2, this is belong to those are all pneumonia cases, not except Theater 1. pneumonia of unknown cause or require ICU care or occur in cluster, or even for those healthcare worker, they will all admitted to the AIR ward for treatment. For Theta 3 is the community acquired pneumonia, relatively stable. They will be admitted to the enhanced surveillance ward to have earlier tests to determine whether they can be stepped to move to those general ward or not. And those finally, we have some community surveillance, sometimes like that. We those patients who attend A&E or in a general outpatient clinic, if they have just fever or very mild symptoms of URI or even mild chest infection, they will have just will arrange the deep-flow saliva test for them, and then where they would be called back if the test was positive. And for those emergency physicians in Hong Kong, we the main business for us during this period will be the emergency services. We are very, very careful and vigilant to try to identify those. We also cause not obvious patients. They may have positive travel history or epidemiologically linkage, and then now we have tried. We have the hospital ward to release their tensions because of the very tight requirement for the AIR. We try to start the A test and triage service. That is where we will arrange the NPS service in our department. People will be waiting in the department for about 6 hours to wait for the result so that we can continuous depends on the result of the test. And also we send some staff to work in the designated center. It is just situated at the Asia World Expo, just next to the Hong Kong International Airport, to help those screening service, especially for those returnees from overseas. And sometimes we have those under quarantine. They have a symptom. They will send to the designated center for screening tests. And also we have some quite a number of people. Actually, they were detained because of those some of the part of the world has been closed because of the disease, like Wuhan and Yokohama. We also send the medical team in the charter flights so that we can make sure that those citizens, the return journey will be safe for them. And also because the demand on medical staff is very, very tight in the acute medical ward. Sometimes we may need to send our staff to go up to the ward to support our physician in terms of the daily service of the acute medical wards. This is the designated center at the Asian World Expo. We have a very big area because this is initially designed for exhibitions, and those so that we can make sure that we enough adequate spacing in between those under tests. These are all those staff working for the test. For the medical escort, this is the charter flight. I'm one of the team, and we went to Wuhan and also Yokohama to bring our detained citizens back to Hong Kong. Besides those services, actually we screen out, especially for the Wuhan service. Actually, one of the flights that is designated for those pregnant lady. You can see that this lady was about 36 weeks of gestation. This may be quite risky for her to take the flight. Fortunately, the flight was only less than 2 hours from Wuhan to Hong Kong, so and the whole flight was quite smooth at that time. And also we do some screening before they can enter those areas to wait for the flight. And finally, this is the current recommendations for the PPE in Hong Kong, and we will the requirement will depends on where you are working, and also whether you are going to perform and some kinds of the risky procedure, especially those aerosol generating procedures. And we basically will follow this rule very, very tight to make sure that all those PPE will be used in a very wise and suitable manners. Okay, thank you. That's all my presentations. Okay.
So thank you, Axel, for that beautiful presentation. So we can take up questions from other participants here for Hong Kong. If you have some doubts or some suggestions, some queries for Excel and Hong Kong.
Excel, can you hear me?
Yes. Yes.
Now, how do these patients come to the hospital? Like, do they self provide the transportation, or do you guys give a government? Yeah.
In Hong Kong, most of those patients were actually quite stable. They will choose most of the time. They will go to hospital by their own transport. So the demand for ambulance was not very high, unless those symptomatic person who came from overseas, and then they will be picked up by the ambulance to the destination center or the hospital for treatment.
Right. Thanks.
Kamarish, can I ask Axel?
Yes.
Yeah, please.
This is Saul here. So I'm looking at your table now, Axel, in terms of the PPE. I'm looking at the hair cover. There's lots of discussion on, especially for aerosolizing, generating procedures. There's lots of discussion whether we can even put a hood in top. And is there any, since you haven't used it and it's optional, is there any concerning, healthcare worker infection?
Well, basically, this table was not designed by us. It's mainly designed by our infection control team. They have a committee to discuss on the require PPE for different procedures or different locations. And for hair cover, their current consensus that it is optional because even though for AGP related, they think that because this is for COVID-19, it's mainly for transmitted by droplets. So they do not think that they need to put into a compulsory one. Although it says that optional one, but as what I observed that for those people who need to handle those suspected patients in the AIR room, or even those in the emergency department, we handle those patients in suspected person in our AIR room. We all wear those hair cover.
Thank you very much. And in terms of the screening, maybe this is the same question to India and to Hong Kong. In terms of the screening, there's lots of discussion. I don't know, Tamarish, maybe we can leave this to the end because a lot of people ask for about the screening process. The rapid screening test for COVID, there has been so many kits out there with very low sensitivity, down in the 30s or so. Some people talk about antigen screening, some people talk about antibody screening. Maybe we can leave it at the end, or it's up to you, Axel, if you have a short answer.
Axel, you can take it.
Sorry, I missed the question. Would you mind to repeat?
It's about the screening. What sort of tests you are using for screening?
It depends. We have two major way to screen. The first of all is by the deep flow saliva test, and the other stream will be using the MPS with the flow swarm, and for those depends on the risk to be infected. Sometimes we may have some patients who just attend our department because of the URI symptom. They do not have a close contact. They do not have any travel history. In that case, we will just order the deep flow saliva test because it is more easier to collect and do not require isolation room for taking a sample. And but even though we still have some positive case because picked up by this saliva test. However, for those who is maybe, for example, for who is from overseas, and also those who is currently under the quarantine order, the chance will be high. And those in the past, if the isolation room is available, we will send them to the isolation ward so that we will let the physician up there to do the test. However, because of the inadequate ARR room, so we try to start this screening service using the MPS in the department, so that those patients will be arranged a test, and with the test, done in our isolation room. And after that, they will be allocated in some designated area to wait for the result. Usually it will take about 5 to 6 hours for the result to come back. If they are positive, we will try to arrange the isolation ward for them, because in Hong Kong, our policy is that all those positive confirmed cases will be admitted, no matter how significant in the clinical conditions, and so they will be waiting for the bed allocated. We have a centralized team in the headquarters of the hospital authority in Hong Kong. They will try to allocate patients, especially sometimes because some patients will gather in those cloud hospitals, I should say. So sometimes some hospital may have more isolation ward, so that the centralized team can help to allocate those patients to share the workload.
Thank you, Axel.
Thank you, Axel. And a couple of things before we move to the next one is Axel, if you can create a Google Drive and put one folder for each countries, and then we can put our own guidelines, which is advised by our own associations or societies or government, to put into that folder, and the other countries can look into those folders, because the guideline is changing every day. And especially in relation to screening, testing, use of PPE. So, we can constantly update ourselves without these things. And secondly, we will move to the next country, but please introduce yourself, because there are other members, guests which are participating. And there are 3 guests from India I'd like to introduce, apart from the ASEM members. One is Dr. Hari Prasad, who is the founder of our society. He's our executive chairman.
See all of you.
So he has joined us, and with us, Mr. Arijit Chobe. He, by training, he's an engineer trained in Australia, but he's actively fighting and helping people who are affected by COVID-19 in the state of Bihar. And his father, Honorable Mr. Chobe, is our health minister of the country, and so he's also helping us on especially the medical fraternity in terms of policies, supplies of PPE. So welcome, Mr. Chobe.
Hello, everyone.
And then we have Mr. Suresh Babu, who is a EMT instructor. Suresh is born in India, trained in India, and I think he's currently in UAE, right? Is correct, Suresh?
Yes, yes. Good morning, everybody.
Yeah. So thank you all for joining us. I will move to, according to my screen, to Dr. Asanka from Sri Lanka. If you can give us an update.
Hello, good afternoon, everyone. Thank you, Tamarish and everyone, for this wonderful opportunity to discuss the country's best practice and share the experience at this vital COVID-19 crisis situation. So let me get my PowerPoint in. Give me one sec. Yeah. So, so this is the yesterday's situation in Sri Lanka. So we have about 190 cases. And for the last 48 hours, we had only one case. But today we had 7 new cases, which I couldn't update it. At the moment, we have 134 active cases, and we had 7 deaths. We have tested about 375 up to now. At this level, the prediction would be around 244, which will be, my guess would be more than this. And this has been the trend. Now, we had first case diagnosed in 27 January, but this is a Chinese worker, and then on 11th March, we had the first Sri Lankan diagnosed. And then it has been kind of a steady growth. And if you go look at the case growth rate, so it's kind of steady and on the downtrend. And this is the distribution of the cases. So it's mainly in Colombo, Chilau, and it's mainly the western part. So we have identified at red zones at the moment. And then age distribution, it's quite similar to the worldwide distribution. So we have more cases in the middle and elderly population. And the growth, gender distribution, unfortunately, males are affected more than the females. Right, so I'll start with the role of emergency means what we have done. So we started our preparation at the first detection in 27th January with the Chinese worker. So we have a national task force for the COVID-19. And also the teams are like, we have few teams working together. So it's a military involved, there's a military involvement. It's the quarantine centers mainly run by the military with the support of the health ministry. And then the accident emergency departments. And we have a good community medicine sector where the pre-hospital, where the public health inspectors and MOH doctors, field doctors are tracing all these contacts. And then we provide pre-hospital care and retrieval of most of these cases under the emergency medicine. So what we do in the emergency medicine, I think it's more or less similar to the most of the countries I have listened to so far, Axel and India. So we have a triage for the COVID suspects, mainly with the symptoms and the fever. So any patient who has fever or respiratory symptoms will go to the fever corner that will be separate from the emergency department, outside of the emergency department. And if he thinks the patient is suspected, according to the case definition, the patient will go to the isolation center and will be tested. And if you don't think this patient is suspected, again, this patient will go home, but with the view of getting home isolation for about 14 days to look for the symptoms. And the community field doctors will be notified about these patients. And if the patient is suspected, the patient will be going to the separate location in the hospital, which are isolation centers. These are mainly governed by the physicians. And once the test become positive, the patient will be transferred to the designated COVID-19 hospital. So we have about 3 hospitals identified at the moment. And so we, as the emergency medicine, we provide the retrieval for most of these cases. So we have 3 hotlines, 2 hotlines where the general public can call and tell their concerns. So, and again, this will be done by the doctors, the volunteer doctors. And then if they think this is a suspected case, they will call our retrieval team. So that's mainly run by the EMTs, but there will be 24 hours on phone supervision from the emergency medicine doctors. So if we think this patient is suspected, again, the doctor agrees, then the patient will be transferred to the isolation facility hospital for testing. And then to manage the staff minimum exposure, in most of the main hospital, we have a telemedicine where there will be no contact with the patient. So it's either telemedicine where you can, you will be taking history via mic, and then with a video, you can see the patient. And if not, some of the hospitals where the patient and the doctor will be separated from the glass window. But having said that, the most important thing now, if we think the patient is unstable or critically ill, the patient will be, that means the category 1 or 2, the patient will be coming to the emergency department. And most of the main hospital have few beds which are isolation facility with a ventilator and monitoring facilities. So we will be taking the patient category 1 and 2 directly to the emergency department for the resuscitation. And so I think this is the most important thing we have done right up to now. So we have done good contact tracing. So this is the graph. So the government military service has done the tracing of each and every contact of this patient. So this patient will be like, and then this information will be given to the health ministry, and with the cooperation with the military and the health ministry, the suspected contact will be sent for the quarantine services with the agreement of the patient. So the contact tracing, we have a pretty good service at the moment, and we have a good field doctor service. All these quarantine, home isolation and home quarantine patients will be reviewed daily by the field doctors and the public health inspectors. So if they develop any symptoms, they will call the government hotline, and the government hotline decide whether this patient needs a testing or not. So as I mentioned, we have a good intelligence service, and we have quarantine centers. Up to now, we have about 44 designated quarantine services. And also there's a home quarantine service. And the red zones, if we think high risk region, we have gone for lockdown. So at the moment, there are about small clusters in a district where are completely locked down because of the high transmission risk. Right, so recommendation of PP, it's again as per the Ministry of Health guidelines with the references from the WHO and the CDC. But again, it's pretty variable, although there's a recommendation because of this COVID-19 fear. Sometimes the general public and even the healthcare sector, the adherence to the guideline is pretty variable, and sometimes under usage, and mostly it's over usage of PP. I think it's the same in most of the countries. So best practice, I would say we do. The first thing, the contact tracing is it's pretty well done in Sri Lanka. And we have this hot and cold area in most of the isolation hospital, where if we have any doubt, the patient will be gone to the hot zone with the healthcare people will be looking after, will be added to full PP protection. We have intubation guideline developed with the experience of the countries where this, with the experience of other countries. That is practiced in the A&E and also in the isolation units. And as I mentioned, the designated COVID hospital. So we have about 29 designated hospitals. I think this has to be updated. It's now become 40. And we have 1 designated maternity hospital and 2 designated hospitals. But having said that, now 2 days back, the Ministry of Health release a new circular. If the patient has a critical illness, if you are concerned about the patient will be transported to the nearest hospital where with the facilities. So it should not be isolation hospital. So whatever the nearest hospital with best facility, the patient has to take the patient and do the first resuscitation, and then only the patient will be transported. And then we have staff quarantine facilities with good accommodation and facilities, and the frequent update on case definition. I think as Tamarish mentioned, the case definition and the guideline has been updating every 2 to 3 days. Challenges. So the first challenge is a risk of delivering the optimum care to the non-COVID-19 patients. So that from the pre-hospital care in the hospital, because this labeling of COVID-19, the stigmata, first thing, we have difficulty in getting the patient to the hospital. Sometimes the hospital refuses the patient. And even from the A&E, getting the patient to a board, again, that's a big problem. So, and I think we have seen some of the non-COVID-19 cases has been not cared enough because of the labeling of testing this patient first. For example, if there's a cardiac event, some of the medical people want to exclude the COVID-19 before they take over the patient. So that's the biggest problem we are having at the moment. And continuous supply of the PPEs, that's again issue. So I work in the Southern Main Isolation Hospital, A&E, as a consultant. So today we had zero stock of N95. So that's a big issue in Sri Lanka, the continuous supply. And proper, sorry for the spelling mistakes, the proper isolation facilities is a big issue. So we don't have any negative pressure isolation area, even in the ICU. So what we do, the air condition and the exhaust fan at the moment, but we don't have any proper facilities. Exit block in the A&E will be a big issue. Although at the moment we are kind of steady with the patient presentation in the hospitals, but I guess if we get a surge of the cases, this will be a big issue, getting the patient. Sometimes we are kind of stuck with the patient because they want the treating medical team, receiving medical team wants the exclusion of the cases. Yeah, so what we have done for the measures to take and promote the health of the frontliners. So we have cut down the roster times. At the moment, the presentation of the hospital has been drastically gone down. So we have cut down the roster. So for example, or we have cut down the doctors and the nursing and all the healthcare workers to half at the moment. So, and again, like they do like stretch 2 or 3 days on a stretch, and they get about 4 or 5 days off. That's with the ministry involvement. And we have given the accommodation facilities in the most of the hospitals, so where they don't want to go, like they can stay if they want, and before, like if they want to during this period of their work. So when they work, they stay around the hospital, and then once they go home, they can stay and be with the family for about 4 or 5 days. And as I mean, if we have any suspicion or if in any isolated, if any exposure to cases, we, for the healthcare workers, at the moment we have about 3 5-star hotels given by the owners for the quarantine process. So we have about 65 staff healthcare workers currently quarantined because of the accidental exposure. And then daily meeting, providing adequate like refreshments and daily meeting and everything we are doing so far. But again, as I mentioned, what I have seen, in my hospital, we had one of the exposure when the healthcare worker get exposed, there's a big crisis and anxiety level peaking up. So that again would be a challenge if we get to the surge of case in Sri Lanka. And I would like to highlight, we had a few atypical cases where about 3 cases came with chest pain, and we had a chest pain and then found to have positive for COVID-19. So which led to the closing down of the few of the medical wards in the leading hospital. And then we had a case where the Sri Lankan came up from Italy, 14 days. And then he had undergone the 14 days quarantine period. And then at the day 20th, he became positive. So this patient has gone through the quarantine process, tested well, so he was okay, and then he was in the community and later became positive. So at the moment there's a discussion whether are we going to get the quarantine period up to 21 days. Sometimes it might take up to 21 days. Yeah, that's all from me at the moment. I would like to take any questions if you have any.
So thank you, Asanka. If any questions for Dr. Asanka or Sri Lanka, we can take it now. Two quick questions.
Yes, Amrish, I had this thing. This is the second speaker whom I'm hearing talking about negative pressure rooms. This is more a droplet infection as far as I know, and it's more of contact prevention and PPEs which matter more. Why are we so worried about negative pressure rooms when it is not airborne infection and when it's only a droplet infection? Is there any reason why all of you are talking about it?
Hello?
Yes, Asanka, you can answer that.
Yeah, yeah. I mean, so we don't need the negative pressure isolation facility for if we are not like if you're not doing any procedures which relate to high risk procedures. These are procedures which can cause aerosol generation. So I mean, if you are examining, if you're taking a history, you don't need negative pressure. But once the patient goes to the critical level, critical stage, you might need the procedures which might generate the aerosol, for example, intubation. So in that case, the best practice would be keeping the patient in negative pressure isolation area, which would be safe for the healthcare workers which attend the patient to get getting the decision contract with them.
Just as a piece of advice, for procedures like intubation or central line insertion, a negative pressure room is not going to protect the healthcare worker in any way. The only protection is if you have a hood. The patient is put under a hood and you intubate under the hood or do the central line under the hood. That gives you more protection as a healthcare provider. So, but the negative pressure, it actually what it does is, it doesn't remove all the virus from the air. It sucks out when it is being aerosol, it puts it onto the healthcare provider. So it only gives a false sense of security. It's a good thing that you're talking about procedures, but I make sure that you have that hood. It's nothing but a simple plastic hood which covers the patient and which allows only your hands to go in and manipulate. That helps you in protecting yourself more while you're intubating or doing a procedure on the patient.
So when we are intubating, we go for the full PPE protection as the recommendations of the hood, face sheet, and even the patient head box and everything. So in Sri Lanka, whatever the centers, if you're doing a aerosol generated procedure, the full PPE will be adhered. But I mean, if you are like managing the patient in a long run in the ICU, would you recommend isolate like negative pressure isolation, or would you recommend a normal ICU location for these patients?
The global recommendations are a regular, well-ventilated room with adequate separation and stuff like that, and to make it extra safe for the healthcare worker. It should be a minimal contact and with the patient. So a lot of ICUs, what we're using is we're putting in cameras so that on a number of, and teaching the patient how to monitor the temperature and how to do certain things by himself. And in critical patients, you have the monitor which is connected to a central monitor. So the minimal contact and minimal intrusion into the patient area is the best way to protect the healthcare provider, and obviously the proper use of PPE is the prime protection.
Yeah.
Okay, so Asanka, if you can stop sharing your screen, I'll move to the next speaker.
Sure. Yeah.
Okay, so I can see Pauline in my screen, the next one. Pauline, most welcome. If you can start your presentation for Philippines.
Thank you very much. And before I start, I'd like to acknowledge the presence of my Vice President, Dr. Bernadette. Hi there. And our chair of the Department of Emergency Medicine, Dr. Cherry Grace Kinking, who's joining us today from Bacolod City, a different city here in the Philippines. She's also a toxicologist, so maybe she can probably share some insights and experiences as well with regards COVID-related topics as we discuss. All right, so I'll be sharing my screen. And just a disclaimer, it will be a very colorful presentation. So stay tuned. Okay, just a moment. Okay, you can hear me, everyone? We're good? Tamarish? Okay. So I'll be presenting here the situation report of the Philippines and the way forward from the Philippine College of Emergency Medicine. And I don't have any disclosure of conflicts of interest. So for the profile and status report on COVID, as a third world country, as a developing country, we have triple burden of disease, and we still have an increased number of communicable, non-communicable, and diseases of rapid urbanization and industrialization. So we are 100 million Filipino, we are 100 million population. And as to date, as of April 10 of 4 p.m. yesterday, we have a confirmed number of cases of 4,195 and deaths of 221. Recoveries are only 140. So if you'll notice here, from the start of our first report of our first case sometime in January, end of January, we have a slow slope of increase. And then our numbers, actually we have a 4.82 daily growth rate. And that will be translated into around 38.8 people infected per million population of Filipinos. Our doubling time is 14.39 days. So if you notice also the distribution in the entire archipelago, because our country is an archipelago and some are contained in the urban cities, like here in Manila, as you see in your screen, and here in Davao City, and somewhere here in Cebu City. So the dark colored areas are the 500 plus confirmed areas, and the lighter shadows, the lighter shades, of course, are the lower volume for COVID. So for our case fatality rate, I was asking Axel because we really have a very high case fatality rate, which is 5.27%, but that is still less compared to the world average of 6.07. Our case fatality rate is 3.34, which is quite better than that of the world average. So we are currently testing 22,958, of which we have 16.9% positive rates and 82.7 negative, including repeat tests as of April 5. So for public health measures that are in place, I have tried to put in a timeline what the government has done for to combat COVID, and we have presented here, the DOH have released these guidelines on the alert levels as to the COVID-19. So if it is alert level code white, there is no confirmed case, and the case is only outside the country. If it's blue, there is an imported case, but it's now in the Philippines or in the country. 3 or blue is the declaration of the public health emergency of international concern. Sub-level 1, red, is that there is already local transmission, and at red sub-level 2, there is no evidence of community transmission. So I'm just sharing that because I'd like to show you again here the screen showing the timeline as to the first reported case sometime in January 30, and then also the interventions done by our government. So here, upon the first report of the first case in the country, there's already coordination with DOH or the Department of Health with the Country Office or World Health Office to begin to carefully monitor the development of these events. There was also strict check on incoming travelers, and there was release of health advisories by the Department of Health. It was as of this time when the WHO already declared COVID-19 as a public health emergency of international concern. Through the days and through the weeks, this is the timeline vis-a-vis the interventions of the government. With the first report of local transmission here, there was declaration of public health emergency by our country, and immediately the code red sub-level 1 was declared by the president. There was suspension of classes, alternative work schedules, it was limitation or restriction of movement of people or here in the National Capital Region. And it was strictly emphasized that there should be social distancing. So here, just like in the other reports, we have also released advisories to close down some of the bars and to also limit concerts and mass gathering and some other events in the Philippines. Sometime in March 12, the Code Red Sublevel 2 was declared because of the report on local transmission and eventually community transmission, which was reported somewhere in one of the malls here in the capital. So from there on, there was this steep rise, not so steep, but this rise. From then on the number of cases, but the number of deaths and the number of recoveries are relatively on a flat slope. So there's this declaration of an emergency hotline, the declaration of an enhanced community quarantine, and we had passed an act an act which is what we call a Bayanihan Act to Heal as One, which gives the president the power to mobilize resources and to mobilize funds for the interventions for COVID-19. As for the strategies, we actually just, as per almost all of us, this is nothing new. We have social distancing. We wanted to identify immediately or early the cases, isolate them, properly triage them to the appropriate health facilities, contact trace and treat the cases. And then we have created quarantine hubs and activation of our barangay health emergency response teams, which is probably something unique to the country. So as of 2 days ago, there was this declaration of now an extended enhanced community quarantine. So we have extended the quarantine beyond April 14, which is supposed to be the end of the community quarantine. So I got all of these events from these reports from government. So this is actually downloadable and easily can be accessed any Filipino, and then I just transpose that into the timeline. So this is one example of our checkpoints where there are temperature checks. So the role of emergency medicine amidst COVID in the country. So we all know that emergency medicine is actually a 24/7 thing, which makes us natural partners of public health. So makes us natural partners for public health emergency. And we have recognized also the increasing role of EM as it stands in the intersection between public health, public safety, and healthcare. PSEM also adapted that perspective, and we have we wanted to also show to the country that we are recognizing that role here in the Philippines. So this is our core values, just sharing that. But if you notice the map that I presented with all the red shades, actually, if we look at the distribution of our training centers, or like we only have 19 recognized emergency medicine residency training programs in the country, you can also see that the distribution is within that area of the red dots. So it's very strategic because our presence there, somehow they collaborate with the training institutions for the different local government efforts for their areas. So the red ones here are government or Department of Health retained hospitals, of which we have strong support from the national government for resource allocation and training as well. So we only have 458 EM members, but around 300 members are actually actively practicing in the country. So as of early January 26, even before the rise of the cases, we already had an ops and briefing for NCOV-19. Then it was NCOV-19 last January 26. So we've done some initial planning to prepare for the possible pandemic. And in fact, PSEM has created this pre-hospital approach to COVID-19 to also involve the Red Cross and to also involve all the other players for our EMS. So we presented them. The role is to present them also with some algorithms from the college, information and education communication materials, such as proper wearing of the masks, protection from spread. And we know that we don't have much data. So that's one of our challenges in the Philippines. So before also the declaration of a community quarantine, we have written the Department of Health and gave them a position statement before they even declared a community quarantine guideline. So here we have presented the balance between treating the individual and treating the public. So that's why we also wanted to communicate that EM is very special in that sense, because we are the gatekeepers and we are the frontliners, if we may say. We are the last defense in the health system. So this was signed March 14 by the board of directors, and our ASEM co-director here, Dr. Velasco, is a member as well. So here we have itemized our commitments. So commitment as to our role in the fight for COVID, but also we have established our recommendations to government. So this includes, if I may just highlight some, the establishment of or provision of field hospitals, because we know that before even COVID, we already have this challenge of very few hospital bed ratios to population. So we're anticipating that. And also that we may have dedicated quarantine facilities for persons under investigation, some step-down facilities for those now stable, and also to decongest the hospital so that we can attend as EM physicians, so that we can attend to the more critical cases. Other recommendations included also that, unique to the Philippines, the extension of the triaging to the fields and from the communities to the barangay health emergency response teams. So there are many here, but some also just include anticipation of shortage of health human resource due to increased absenteeism perhaps from quarantine or illness, and appropriate triaging of patients at the EDs following our clinical algorithms. And if we may request for hazard pay compensation, because some do not receive such hazard pay compensation for both the government and private healthcare providers because of the increased risk of our work. So there, the congestion of hospital wards, so that for those who can be discharged early and down the line. So also we have recognized the importance of mental health early on. So we wanted to also provide them, our healthcare workforce, with regular debriefings and psychological first aid, and to establish tele-emergency centers or services through clusters. Because if you notice, our country is an archipelago, so we really need to be strategic about our interventions, because we cannot make it. It's difficult if we really wanted it to be central, because different local governments have different needs as well. So another aspect that we had collaboration with was with our Integrated Bar of the Philippines, composed of our lawyers and some other societies, medical societies, as to regards the voluntary waiver of disclosure of whether the patient is COVID positive, or if the patient is a person under investigation. This happened because of the initial sets of patients are healthcare providers themselves, because of this non-disclosure of our patients. So we became victims of such non-disclosure of those patients. So of course, we all know that we are not just clinicians. We are also logisticians. So we have so many hats to wear as an emergency vis or as an emergency doctor. We are clinicians. I'm actually post-duty. That's why I'm still here. So we're clinicians first and foremost, but we're also engineers. So we try to create so many things that may just some sort of be barriers, or just to have a barrier to the issues that we have. Even ED design, even the interior designers, even human resource managers, if some of our colleagues are absent, researchers and advocates. So initially, the very first thing that an EM did in our country is, of course, immediate ED redesign, because we all know that we need to have different paths for these sets of patients. So it can be as simple as this. So different institutions have different ED designs depending on their structure, depending on their human resource as well. So the challenge was really breaking down the silos and highlighting that emergency medicine has a presence in the hospital, and that we need to also, because in the country it is still very young, so we need to communicate this to the other more established specialties, if you will, like the infectious diseases, internal medicine. So we needed to have a spot to be heard and to to be considered in all of our in our ED. So as a product, as an output of that, we were recognized. This is in one of our institutions, the Philippine General Hospital, one of the biggest hospitals in the country. There was a shout out to recognize the importance of emergency medicine. So that for us is already a big accomplishment, having been recognized by one of the more established institutions here. So with all other engagements, we are now collaborating with the Philippine Society of Hospice and Palliative Medicine, because we have this ethical discussion because of the hesitance of some of our doctors to render immediate resuscitative care, because we don't really know from the onset if they are COVID positive or not, or if they're PUI or not. So the hesitation is that some do not wish to do the codes anymore. And of course, with the challenge also of inadequate or not an appropriate PPE at the time. So we have decided to collaborate with the palliative medicine for early communication guides for our in extremis patients or for those patients who are already critically ill and cannot be, like, for medical futility. So we need to have a communication guide on that. On another note, we're also collaborating with the University of the Philippines as to the guidelines on resource allocation. So primarily the ethics guidelines was drafted initially because of issues on resource allocation and triaging, deciding who will have the ventilator or not, deciding who will be admitted or not because of resource issues. So this will be finalized by Monday. So we will have another meeting on Monday. We've had 2 meetings. And we'll update you also on the outcome of this collaboration. With the Philippine Society of Public Health Physicians, we are working on a field guidebook for health facilities with low resource setting, because not all of our institutions have similar profiles. We have
Pauline, you have 2 minutes.
urbanized, but we also do have units in. Yeah, okay. We also have health units that are also not so blessed. So okay. What are the operational guidelines? The DOH takes care of that. So we have interim guidelines. They produce that and publish that periodically. And these are our guidelines for our healthcare facilities, the decision if the patient is PUI or PUM and for admission or not. And we also have this risk assessment for healthcare workers and healthcare assessment for return to work criteria, when they turn out positive or not and when they can return to work. So recommendations for using PPEs, we practically are following the DOH and the World Health Association guidelines, but we do understand that these, we need to do rational or judicious use. So we have this prescribed PPE that's according to also work area and according to your exposure. So for best practices that other Asian countries can adopt in this situation, we have briefers. I'm pretty sure that you also have your own press briefers. That's daily. And we also get from our values the bayanihan spirit, which is helping each other. So Manila, despite the pullout of over 100 medical interns in one of the biggest institutions here, the students decided to stay still to boost the morale of the other healthcare providers in the university. So even when they were told to be pulled out, they decided to still stay and help. And because it is the right thing to do, as what the hospital director said, the PGH, or the Philippine General Hospital, is now committing to become one of the main COVID referral centers in the Philippines. So as for other best practices, our healthcare providers who cannot go home because of our community quarantine, our mayor here in Manila have decided to ask our hotels for accommodating our health workers for free. So these are some of the hotels and some also of the buses who give free rides to and from work. Just some pictures. Unfortunately, there was this whole departure order for Filipino healthcare workers just to augment the healthcare workers. It's fortunate or probably unfortunate for some whom they cannot leave. So some also have decided to donate their salaries to some of the hospitals here. And one of the main currently that's being done right now is the conversion of public spaces to quarantine hubs. So this is a sports arena being converted now to a quarantine hub, and the perspectives, some of the views there. And these are also the other public areas that may be converted to quarantine hubs if needed. So this is the BERT. That's the one thing that I was telling you about, that it's specific to a very small village, sort of a response team for each village, which monitors all of those who have been quarantined in their areas. We have also the EndCove bot. And for some unique also probably here is that some institutions have decided to forego the usual 8-hour shifts, but have decided to do it on a 1 to 2 weeks duty, then 2 weeks off, which corresponds also to the quarantine. So there. So challenges, this is probably part of the last slides. Challenges, we need really urgently real-time data because currently we only have hard data, which we do paper and pen method. And we get this from the case investigation form and lab info system. We have some healthcare workers who've had violence against them. This patient was, a bleach was, he was harassed. So splattered by bleach on the face, thinking that he has COVID. So our police are currently helping our healthcare workers to accompany them to and from work. So that's one of the interventions that we're currently doing. Of course, shortage of PPEs, but the government is doing something about that already. And one of the major issues here is because of the non-disclosure initially, we've had initial deaths that are healthcare workers themselves. So I'm saying this because 63% of the deaths are actually healthcare workers. So we've lost our first emergency medicine doctor last April 6th, and we are mourning currently in the country. So 252 healthcare workers are COVID positive, 65% are doctors, and 25% are nurses. And this cannot only be attributed to shortage of PPEs, but also that of the non-disclosure. That's why the collaboration. Displacement of healthcare workers because some of them are turned away by their landlords and landladies. So what do we do about it? So as Filipinos, we're very happy people. So if to promote our safety and well-being of the healthcare workers, we just smile, laugh it off. But the best for the most with the least by the fewest is our mantra. We need to plan, prepare, prevent, and protect. So for mental hygiene practices, we have the Philippine Health Association for mental health. There are some efforts on that. Food, overflowing, words of encouragement, appreciation wall. The Philippine Health Insurance is committed to reimbursement of some of the expenses once a healthcare worker gets ill. And of course, there are so many other overflowing words of encouragement from the rest of the community. So if we're very colorful, so happy people. So from the shortage of PPEs, that's why we have colored PPEs, because we have decided to make our own PPEs. So these are from couturiers all over the country and designers who've wanted to donate in style some of our PPEs here. So there you go. That's the end of my presentation, Tamrish, and thank you very much. I'll be happy to take your questions.
So thank you, Pauline, for your wonderful and really colorful presentation. And there are a lot of things to learn. One of the things is that how to respond at the village level. I think a lot of Asian countries will be interested in that. So same request. If you can put that into that Google folder under the folder of Philippines, then the other people can take that forward. So if you can stop sharing the screen, I will move on to the next.
All right. Okay.
Yeah, so thank you for that again. So we don't have much time left, and I guess there are 3-4 other countries which have to speak. So I'll quickly move on to UAE. Saleh, are you there?
Yeah, Tamarish, hi, how are you? I'm here.
Good. So if you can make a quick presentation, maybe 10 to 12 minutes.
Hopefully less. I just want to thank everyone for the opportunity, and I think I want to congratulate everyone for taking the lead on this important crisis and very challenging. I think we haven't faced in our own history as a big of a crisis, but I think the emergency physicians are proven to be leaders in this field. So I will not take much. I'll just follow the, unfortunately, I apologize. I thought it's a table round, more of a discussion, but I will go over the questions. So currently in the UAE, in terms of numbers and data, if for those of you, the UAE is 9.7 million. We are 7 emirates, so we have a federal system. Each government has its own local government, but the Ministry of Health oversee the healthcare system overall from a legislation and oversight. Then on top of that, we have, for those familiar with the Emergency Management Agency, FEMA in the US, we have a National Crisis and Emergency Management Authority here in the UAE called NCEMA, where they are running the show now in coordination with other ministries. The total cases, confirmed cases we have so far is 3,360. Of those, 418 recovered, and we have, this is as of today, 2,926 cases, active cases, and we have 16 deaths, unfortunately. Some people just, again, there's so much of information and lots of discussion, but the increase of cases, more of two factors. One is the UAE is very active on screening. So far they've screened, they have drive-through screens, activities. I'm going to talk later on in the public screening, but also at the same time, more of, we have different, for those of you who know the UAE, we have labor camps, we have, clusters of communities. So those being a little bit challenging, but the UAE's government is paying, clear attention to this and trying to minimize the spread on those communities. The role of the emergency medicine in this mission, obviously, definitely taking a leading role. The emergency department, unfortunately, play in general in the UAE here, play a primary role also. So we do still have, despite all the community awareness and other factors, we do see low acuity cases in the emergency department. This was decreasing before the pandemic, but now it's coming up because a lot of people are worried, but they are well. So a lot of planning, a lot of discussions going on this. What are the public health measures? Like many of the Asian countries, social distancing being very heavy. The UAE, again, because of the federal system, some cities like Dubai was, because of its active and very economy driven, the airports stayed until some time, and that maybe affected a little bit of the surge. But now there's a full lockdown, 24 hours in Dubai. There's a national, we call it a national disinfection program. More of a lockdown, but it's from 8 p.m. to 6 a.m. every day. There's very heavy enforcement of social distancing, wearing masks, hygiene, limiting activities. Schools are shut, very similar to many countries, cancellation of big events. So this being very heavily enforced, but again, like many other communities, compliance from the community depends on their social economical status and their knowledge. So that's been challenging at some levels. What are the operational guidelines? We didn't, ASEM or the Emirate Society published a position statement, again, very close to the ASEM recommendations. But in general, we follow the Ministry of Health guidelines in terms of management. Most of what we enforce is this separation of COVID and non-COVID pathways. We're trying to limit the involvement of emergency department for COVID patients, unless some, it depends on the structure, obviously, of departments. Some departments are small, so they're using tents, they're using other side of the hospitals, and some others are being using different sections of the department, of the emergency department. So again, emergency department are taking a leading role on this. What are the recommended PPE? I think we addressed it enough. I'll leave it maybe later on to the discussion. But we're, again, WHO and CDC recommendation. There's lots of gray zones. There are lots of concerns on PPE, stockpile, and that sort of things. What are the best practices? I think we're all learning from each other. So I think enforcing the social distancing, screening, although it's expensive, and that's, again, a factor that might be limited by income of the country. But the earlier we detect the positive cases, the easier we can, identify them, lock them. There are applications now used in the UAE to track. So I registered myself. So they can warn you if there are positive cases around you. They can track people for those who are leaving houses. So the UAE, for example, many, especially Abu Dhabi, where it's the biggest, so people can track positive cases using their phone, their camera. For example, if you're not allowed to leave, if you're in mandatory home quarantine, and you use your car to leave, then you are subject to legal. It's a big deal, actually, in the government now. So that's been very heavily enforced by the government, and hopefully it blunts the curve. The last thing is in terms of the healthcare worker and physical and mental. It's similar to our colleagues in the Philippines and many other countries. I think we are the heroes now in any country. We're the frontliners. There are signs all over the country now of thanking and encouragement. Many, similar to the Philippines, again, hotels offering services, companies offering free services, restaurants, so many others, even Starbucks here offering free coffee to healthcare workers. So many countries are encouraging healthcare worker. Obviously, the mental health aspect is very exhausting. We depend on guest workers from other nations, especially India and Philippines, who've been doing an amazing job in helping the country to manage this. But at the same time, the demand is increasing. We're trying to make sure that there's no burnout. The rotations, the government have lowered the involvement of high-risk healthcare providers, over 60 in the UAE here, mothers with kids, also pregnant women. All of them have been exempted from work, and they're going on paid leave. So those things been very helpful, trying to minimize the risk, but like many other countries, we're facing some challenges. In general, I think the two factors that I see working in the UAE, but also the same thing is a challenge, is basically one is the communication. Like any other crisis, the communication, because we're federal, we do hear different practices sometimes in different emirates. But the Ministry of Health has a press release. They have very unified, all the healthcare agencies unifying their messages. The second thing is in terms of the community involvement, media awareness, social media, all of those activities have been very helpful. And we hope that we, like many other countries, we just overcome this crisis in the short term. Thank you, and I'll be happy to answer any questions.
Okay. Any questions for Saleh and the team in UAE?
Suresh, also, if you want to add something, I apologize.
No, that's fine. My questions I will ask at the end because it's in general questions.
Okay, so I think if I'm not wrong, there are two more countries to speak who are present here, and correct me if I'm wrong. One is Taiwan, the other one is Indonesia. Is there any other emergency medicine physicians, other staff from other countries? If not, then I will move to Taiwan, because Taiwan story is getting quoted in a lot of news media across the world. They seems to have flattened the curve. So I'd like to know what is an update from Taiwan.
Okay. Happy to meet all of our colleagues. Can you hear me?
Yes.
Okay. So thank you for Tamois for organizing the conference. Because we are also quite busy, so I did not prepare a presentation. So I just want to answer for the Tamois question that now we have the 385 cases confirmed, and only 10% are from the local. Most are coming back from the overseas. And in the recent 2 days, we have only a individual case reported. I think this is because of our government, they have a everyday public announcement. So to let all the people know what is going on. And there's also a very close tracing policy. For every contact case, we have a very close tracing policy. So everyone will know what where the confirmed case go, and everyone will take care. If they have any symptom, they can go to the emergency room for screening. So I was now going to the role of emergency medicine. In our country, 90% of the screening process are done in the emergency medicine area. We have an outside tent like Hong Kong, and we do the PCR, and we do the nasopharyngeal swab in order to prevent the coughing or the vomiting process to contaminate our staff. And also we develop some protecting shield, so like a plastic cover to when we are doing these procedures, so that we can protect our medical staff from this nasopharyngeal testing. And also we go to airport, our government asks our emergency medicine go to airport to do the screening from the overseas comers. And next, I will be stressed on the PPE. I think the PPE is very important to our healthcare workers. And also, we carry a small box of alcohol with ourselves, so that everyone in every contact, we can use the alcohol to do a proper hand washing. And we now wearing every glove. We glove when we contacting our patients. And also for our country, we implement the telemedicine for quarantine patients. So we avoid them to come out frequently, so we can use the telemedicine to answer the question. For every confirmed cases or suspect that need to be screening, we will arrange an escort taxi or the ambulance for the confirmed cases. For suspect, there's an escort taxi system for the patients to come instead of they going to the public transport or buses or any public transport or trains. So we have a special design escort taxi for this. And finally, I would just want to talking about the medical staff support. So because our medical staff are not allowed to go overseas, so now the government will compensate for any loss for cancel the hotel or cancel until June 30. So we are not going to Argentina also, but they already canceled for the meeting. And our hospital, I would recommend, we prepare accommodation, hostel or room for any workers who don't want to stay at home because they are worried about if they got infected, they can transmit to their home members. So for our medical staff, when they care for the confirmed case, they can ask to stay in the accommodation room that our hospital provide for the single room, so that they can don't worry that when they, if anything wrong, they will pass it to their family members. And also now the focus is to prevent hospital outbreak. So we have clear guidelines for staff quarantine procedure. And also we pay for the staff if they need to be quarantined. So now if any staff, they have fever or cough or respiratory tract symptoms, they will be enforced to rest, and they will be tested for COVID twice before getting back to work. And like SAE of Philippines, the society also donate or offer foods or drinks to the medical staff. So this is currently I want to report, and I would like to take any questions. Thank you. I cannot hear you.
Thank you. Any more questions?
May I ask?
Yes.
Okay.
Yes.
Dr. Ung, may I ask how you do your rotation for your work schedule for your staff?
Okay, for emergency, we now have two separate teams. So we will work about 7 days a shift, and then the next team will go on 7 days. Because now the emergency visits are all actually declined, so that we can help to separate in our major hospital, we are now doing this 7 days a week for staffing. And also in our ED, because now our government need for any pneumonia cases, they say there will be a distance. So we also set up a emergency settings that for every pneumonia case, we will test for the COVID, even if don't have the TOCC history, but we will widen the distance about 2 meters per room and have a curtain to protect them. And then we test, but actually our hospital will test for about 1,000 cases of pneumonia. Actually, it's not a single one now without TOCC have COVID. Yeah.
Thank you very much for that.
Okay, thank you for your presentation. I think Ali Haider had to leave because he has clinical shift. So we will not have an update from Indonesia, but he said he will send an email. Is there any other country which is representing in this panel? Was not spoken so far. Okay, if not, then we have a couple of guests which have joined us. So I'll give them an opportunity of about 2 to 3 minutes to put their perspective. So I request Mr. Arjit Chobe, who is again by training is an engineer based in the state of Bihar, and he's doing a lot of welfare activities. So my question to you, Mr. Chobe, is how we can provide or how we can protect the healthcare workers and the patients in remote areas, because so far a lot of countries are doing responses which are mainly city centric, but as like our country is concerned, areas are villages, remote areas. How do we protect the public and the healthcare workers in those areas?
Welcome everyone. Basically, what we are doing for the rural population of India, the government has taken so many initiatives, and particularly if we are talking about the rural and the remote areas, we have got different states in India, and all the states have been properly notified by the central government that there should be a central system working at the state level. So all the headquarters has been connected with the central monitoring system in New Delhi. There is a war room, and if we say we have got a few centers of ICMR, because ICMR headquarters is there in all the states in the country. And what we feel is we get the samples from the remote areas directly to the southern hospitals, so the city hospital, and then it is being brought to the main headquarter, which is the state headquarter. So basically, if we are very particular about the COVID-19 situation in India with a population of 1.3 billion. So altogether, the cases is around 7,000. And very particularly, what Dr. Kole is asking is about the rural situation. So the government of India is acting very well, and telemedicine has been initiated to all the centers in the states. So altogether, if you see, 31 states and union territories has been heavily affected by the COVID-19 situation. So we have connected all the centers through telemedicine also. CCTVs has been initiated in all the district hospitals and the PSCs, primary health centers. So to get get a check also, we have the quarantine centers available at the panchayat level. So you can say at the village level, we have got the quarantine centers now. And at the district level, they have initiated with the district hospitals 500 bed reserved for this corona virus disease, patients whoever comes. So altogether, we have done this sort of thing for the rural population. One thing more to be added, because India's rural population is around 75%. So your question is very good about the rural India. But what I mean to say really that the affected people are not residing in these rural areas. So they are residing basically in the cities who have come from outside India. And whosoever are there, we are taking them to the quarantine centers and to the district quarantine centers. And if it is required, we are giving them proper treatment even in the state centers what we have prepared in the headquarters. So altogether, there are so many things going on to fight with this corona and to defeat it very well. With a huge some population, we are doing very actively, and proactiveness we can see among the doctors and the practitioners and the health workers. So basically, these are the people who are doing too much for the country and for the benefit of the country as well.
Thank you for that, small update and concern about the villages and the people there. And I'm sure the government of India will do everything to flatten the curve, and we may not reach that peak as we are seeing in some of the Western countries. So I'll quickly.
I need to, Tamarish, I just need to add one more thing, that the government of India has taken a very big initiative of launching a Arogya Setu app, which has been, it's a medical bridge app, where you can connect it from a village, we can connect from anywhere. And I think altogether, more than 10 million downloads have already been taken place in, I think, 3 or 4 days. So that's a very big initiative by the government as well, directly taken by the Prime Minister of India.
Right, yeah. And I myself and my family members have downloaded it as well. So it's a very effective app. I do agree with you. I'll quickly pass on to Dr. Divyansh Gulati, who is working, I think, day and night in NHS in UK. And UK is one of the country who has seen one of the worst peak, if I may say, in Europe. And I would like to know that is there any thing for us in Asia to carry forward from NHS, the learnings and lessons? 3 minutes.
Thank you, Dr. Kole. Yeah, so I think we have been affected a lot, especially because of significant travel history, people traveling to and fro a lot to Asia, to the Europe. Although we are not the part of Europe now from after the Brexit, but still, the COVID crisis started all before that. The important message which I would like to give to my Asian friends is, and what we are doing in the UK at the moment is, we have divided the emergency department into a red and a green zone, or a dirty or a clean zone. So what we usually do is any patient who is a suspected COVID has a different entry and a different exit into the hospital. So that because you will still get some non-COVID patients who are coming to you, and you have to make sure you do not mingle them together. The second thing which we have done is, as a national policy, is all out of hospital cardiac arrests are COVID until and unless proven otherwise. Because what we don't want is that we don't want to infect the healthcare workers who are on the front line, and by assuming an out of hospital cardiac arrest, whether it is COVID or non-COVID. So until and unless you see an obvious knife in the chest or an obvious gunshot wound in the head or the chest, so if it's not a traumatic cardiac arrest and it's a medical cardiac arrest, it is COVID until and unless proven otherwise. Regarding the testing strategies, with the limited resources of kits, PPEs, and it's an international problem ongoing, we are only testing at the moment people who require to be hospitalized. And then in the last 1 week, we have started swabbing the healthcare workers and the frontliners, because if you lose the staff who are working, then I'm not sure how long we can run the show. So, important message which I also wanted to bring across is, at the moment, all respiratory conditions for us is COVID until unless proven otherwise. The travel history is not a significant part of our collateral history at the moment. So we have designed different units, and we have divided the emergency into many phases as well, so that when surge hits us, all the surge is there in London, but I'm 45 minutes away from London. When surge hits us, we are prepared to cope with it. I think probably that's the important message which I wanted to get across. Thank you.
Thank you, Divyansh. So we have almost finished our time. We have 10 more minutes. So the forum is open for discussions or questions or comments. Anybody can speak.
So now what we seen in Sri Lanka is the providing adequate better care for the two things. I mean, providing good care for the COVID patient is a significant issue with the stigmata. And then what we see, the non-COVID patient is also not getting the better, like the best care, because now if the patient comes from a red zone without any COVID symptoms, still some of the hospitals and all the healthcare workers has hesitancy to provide the care. Is it the same you all are seeing in your countries with regard to these aspects?
I'm happy to answer it, Dr. Kole, if you want. Yeah. Okay, so the degree of uncertainty and anxiety is massive everywhere, be it the UK, be it any country. I think what we have done, especially the consultants and the senior people in the department, they're already leaders, but I think they just have to sometimes work out of their capacity. And it is addressing the staff again and again, that what we are following and reinforcing that these are national guidelines. Probably what we usually do in our hospital is, any PPE update, we post it on a WhatsApp group, and we have made videos of the staff dressed in appropriate PPEs. So we have made different photographs stating, this is a red zone PPE, this is a green zone PPE, and your own staff is showing that. This helps people to get related, that yes, if my staff is showing, there is a trust over there. So I think these measures are quite helpful in our department at the moment. Definitely the degree of uncertainty is more among the patients as well, that if they come to a hospital, are they going to catch COVID? And you don't want somebody with severe injury, severe illness sit at home and think he might get COVID if he goes to the hospital. So probably the message has to be quite clear, especially it can become from the society stating, we are open for business 24/7. If you need us, you come to the hospital. We have our pathway sorted. So the message going to the public is also very important.
Yeah, I mean, yeah, I agree with you. Now, the problem in our countries, I see, now in UK, it has gone up to the community level spread, but in like Sri Lanka and most of the other countries, it's not gone up to the community level spread. So I think it's really unfair by the patient to not to provide getting this stigmata, because like in Sri Lanka, for example, in my country, if we get out of hospital cardiac arrest, in a non-lockdown area, which is like a small part of Sri Lanka only. So we should provide the best care. But having said that, we will be having small risk of getting this patient asymptomatic carrier. So that's the stigmata and that's the dilemma happening in Sri Lanka. And we have seen so many problems occurs because of this problem. I mean, when we go to the community level spread, if that happens, then this strategy has to update it for sure. But at this stage, I think in Sri Lanka, with the opinion, we need to provide the best care unless we have the patient coming from a red zone.
Yeah, Suresh.
Dr. Tamarish, can I ask a question?
Yeah, please.
I think this is open to everyone. So there is also a feeling of uneasiness and anxiety among the EM workforce, which we are beginning to notice. I don't know how it's the experience in your countries, and we in a leadership role, or you in a leadership role, how you are addressing to some of this. I think part of this is because of the social media shares which are happening with what's happening in some of the Western world. I think this clear sense of anxiety building up among the EM team. Is there any advices from any of you on how you are managing in your particular country or in the departments to bring or to boost the morale of the team up?
Can I tell my experience in Sri Lanka, Sarwanka?
Yes, please.
Yeah, so I'm kind of supervising the 190 in Sri Lanka. That's our EMT program. So I totally agree. Now there's significant level of anxiety in the EMTs. But having said that, we have to have sympathy on those aspects also, because they will be exposed to these uncertain amount of patients. Sometimes they don't know about even the contacts. So we are kind of at this stage, we are kind of very lenient about the PPE usage for them. So if they have any doubt, we have allowed them to go for the full personal protection equipment. And if the patient coming from the red zone, those are the high risk areas, definitely full PPE. And if the patient is critically unstable, not critically unstable, then the EMT will travel front and the patient will travel in the compartment. And the other thing now, so we have developed our CPR guidelines. So out of hospital cardiac arrest, in case of in the red zones, we don't provide CPR. So that's the general consensus. So so EMT, they will not be providing any CPR if this is from the red zone. So that's the current practice in Sri Lanka. But I agree, there's significant level of anxiety. Some of the EMTs, they kind of feel really anxious when they go to a patient, even non-COVID patient. But again, we have to we have been really sympathize on these EMTs also, because they kind of expose into unknown patients, which may be asymptomatic carriers. We don't know.
Okay, so we have reached almost the end of the session, and thank you all for joining. And I'd just like to summarize, what we have discussed in last 2 hours. A couple of points which actually emerged in my mind is that, of course, we are creating that drive so that we can update our policies and protocols of respective countries and we can share with each other. we have to look into the reuse of PPE because that's a challenge across Asia. So, as per India, we just had, a guidance from one of our premier institutes. So we will post that and we will try to develop a guideline for Asia. Then there is a lot of requirement for extending care through telemedicine and networking. So that is one area where we can work on and use technology-driven solution which are easily replicable, not very resource intensive, so that we can connect to our remote areas. As per the hospital redesigning and staffing is concerned, I think most of the countries are working on the similar lines. So if you can share our guidelines on staffing and zonings of emergency department, it will be very, very helpful. Then for pre-hospital colleagues, I think India has already launched an SOP and Philippines have come out with new guidelines. I'm sure the other countries also have, because the EMS colleagues are also in the front line just like us, and they should be also protected and they should be also given guidance, and we're working hand in hand for them. And then there are a lot of support which is required for healthcare workers, including emergency medicine professionals, in terms of their quarantine, in terms of their accommodation, their food, their transport, their mental health support. So those are other areas where we can, I think our society can work on that. So on that note, thank you very much for joining, and probably we will have one more Zoom session after 2 weeks to recalibrate our positions and our situations, and and we think of the way forward. Thank you once again for joining. Thank you very much.
Thanks
Thank
a lot to all
Thank
of
you.
you. Special thanks to Dr. Kole to bring us up on Zoom. Thanks a lot.
Thank you.
Thank you all very much.
Thank you all.